Hi, my name's Julianne Campbell. I'm the General Manager of Development at Sydney Children's Hospitals Foundation. It gives me great pleasure to invite you all here today for the Foundation's first webinar exploring innovation in paediatric medical research being undertaken by Sydney Children's Hospitals Network. The Foundation was first introduced to Professor Tom Snelling a few months ago, and we were invited to partner with Sydney Children's Hospitals Network and the University of Sydney to support Tom's Learning Health Systems initiative. Since then, we have been actively fundraising for what we believe is a groundbreaking project in terms of the impact this can have on paediatric health in Australia and beyond. Today, we are delighted to have the opportunity to hear directly from Tom about how he is implementing a health learning system and how the work that he's doing through that is informing collaborations in New South Wales, Victoria and Queensland with teams of researchers and medical professionals on a national response to fast-track patient outcomes, patients who have COVID-19. We also have the very esteemed Professor Robin Ward, who will be in conversation with Tom as they step through and unpack why this adaptive approach to clinical trials is so necessary and how data can and needs to inform and drive real-time decisions being made in terms of delivering patient care. Before we begin, I would like to acknowledge the traditional custodians on the land we are gathered today, which is at Sydney University Camperdown campus, and that is the Gadigal people of the Eora Nation, and I give my respects to their elders past, present and future. And I would also like to acknowledge the traditional custodians of the land where you are today and give my respects to elders past, present and future. Just a little bit of housekeeping. We're going to record today's session and that will be sent to you via email at the end of the session, and it will also be available on our website, the Sydney Children's Hospitals Foundation website. We're going to start with a couple of questions and in conversation between Robin and Tom, and then there will be an opportunity for questions from you, which you can put into the live chat directly on the webinar, and you'll see that little box off to the right of your screen. But without further ado, I'd like to introduce the very esteemed Professor Robin Ward AM. She is Executive Dean and Pro-Vice Chancellor at the University of Sydney. She is an academic leader, a cancer researcher and a medical oncologist. She chairs the Commonwealth Medical Services Advisory Committee and serves on the Council and the Executive for the Australian Academy of Health and Medical Sciences. In 2013, Robin was made a member of the Order of Australia for significant service to medical research and patient care in the field of oncology. We are delighted that she can join us today and be in conversation with Tom, and I'll hand over to her now.
Thank you very much, and hi Tom. It's great to be here with you, talking to you about your favourite topic, a topic which I think everyone will be very keen to hear about. But perhaps if you could just start by telling us a little bit about yourself.
So I'm a paediatrician by training and an infectious diseases physician. So I have my substantive clinical role is at the Children's Hospital at Westmead, but I'm also a researcher and an epidemiologist here at the Sydney University School of Public Health. And I lead a team called the Health and Clinical Analytics team. And we spend our time working out how to best evaluate care and implement improvements in management of children and adults with various health problems.
Great. And so one of the topics for today, and one that I think I'm really keen to hear more about, is about what this learning health system is. So in lay terms, can you describe what that actually means?
Sure. So a learning health system is quite a simple idea. It's just the idea that health systems have to do a whole lot better at evaluating the care that they give, to learn from that in order to be able to implement change and to improve the care that they give to their patients. And that might seem very simple and surprising that we don't do that already, but in fact most hospitals don't do a great job at that. And so the US, the Institute of Medicine's put out a white paper about a decade ago. They were basically looking into how it could be that billions of dollars could be invested in health and medical research. We can have all these breakthroughs, and yet life expectancy in the US was stagnant. There didn't seem to be any improvement over decades, and in fact in the last couple of years it's got worse. And so what they pointed to were these deficiencies in how different treatments are evaluated within routine care, and they were making the argument that actually the evaluation of care and the delivery of care needed to be linked together, and that evaluation should be an integral part of the delivery of healthcare. And so they identified 3 basic steps. So the first step was collecting data, so collecting information, trying to collect useful and accurate information about the sorts of treatments that were being given, and also the outcomes for people who are receiving different treatments within a health system. And then the second part was to take that data and to convert it into knowledge. And in fact, we would go a step further and say it's not just knowledge, it's actually understanding. How can we use that data to actually understand the underlying disease process and also the process of delivery of care? And then the third step is taking that understanding and then using that to inform better treatment recommendations, better advice, and improvements in the delivery of care, improvements in practice. And the critical part of a learning health system is that has to occur in a cyclical and iterative process. So once you implement those improvements in care, you need to collect the data and again evaluate to iteratively grow over time your understanding of the disease and improve care. And as I said before, a critical part is embedding that within the delivery of healthcare. Stop looking at the delivery of care and evaluation of care and research as 2 separate endeavours. They need to be one and the same thing.
So it seems like it's such a compelling argument. Why have health systems and clinicians been so tardy about picking up this idea?
Yeah, so I think part of it is a cultural thing that culturally we see delivery of care and evaluation of care as two different things, and overcoming that demarcation between what a health system does and what a university or a research organisation does has taken time. But also we haven't always had the best tools that allow us to simultaneously deliver and evaluate care, and we do have those tools now. So in a traditional health and medical research paradigm, as you will know, the way that we evaluate care has traditionally been divided into 2 basic types of research. There's observational research and there's clinical trial research. And in observational research, basically a researcher pulls out medical records, tries to find out who's received what treatment, try to work that out from the notes, and then tries to work out what happens to patients who have received different types of treatment to try to work out whether one treatment has appeared to work better than another treatment. And as you can imagine, that is really difficult because it's labour intensive to find these records. And often clinicians can't even understand their own notes, let alone have a researcher come in and try to understand a clinician's notes to work out what's happened in the past. And then the other problem with observational research is it's often confusing to try to work out whether someone has done poorly because they've received a treatment or whether they've received the treatment because they're doing poorly. So that's this problem of confounding. And that's the sort of thing that is very hard to disentangle with that sort of observational research, which is why for many decades clinical trials have been seen as the pinnacle of research because they can disentangle cause and effect. But clinical trials, or at least the traditional way we've always done clinical trials, is quite burdensome. And the way that we do them is basically the same as the way that we would set up an experiment with laboratory mice. That we try to make the situation as controlled as possible, keep everything as constant as possible, and then we artificially assign some people to receive one treatment and some people to receive another treatment, And then what we do is, once we've decided how many mice or patients in this case we're going to evaluate, we make this decision that we're not going to look at the data until we've collected and enrolled that many patients. And what that means is that even if you have a treatment that is doing really well, or a treatment that's doing really poorly, usually we don't do anything about that until we've got right to the end of the study. And that turns out to be very inefficient, for one thing. And secondly, it's not very fair on participants either. And so it can be very hard to convince people to participate in traditional trials. And so typically in clinical trials is, we might only have a very small fraction of people who have actually got the disease who actually agree to participate, and that becomes very artificial, and it can become very difficult to extrapolate evidence from a clinical trial into the real world. But we now have the tools rather than look at observational studies and trials as two separate things, actually take the best of both of those things, use the randomisation from clinical trials, but also the all-encompassing nature of observational studies.
And just taking you back a couple of steps, you mentioned that these tools are now available that perhaps weren't before. Could you just say a little bit about what those tools are?
Sure.
That have perhaps made this now possible where it wasn't possible before to adopt the approach that you're talking about?
Sure. So the tools, so there are a few tools. So firstly, increased digitisation of medical records. So up until very recently, hospitals across Australia, and still to this day, most hospitals still use paper-based records. And that makes it very difficult to collect data. But now hospitals are coming on board with electronic medical record systems. The Children's Hospitals in Sydney were amongst the first hospitals in Australia to come on board with electronic medical record systems, and that means that the capture of data is much more efficient than it ever was in the past. So we're now actually drowning in data. The problem is the analysis. How do we actually analyse that data to gain the insights? And there have been some tremendous developments in how we analyse data. So the way that we analyse traditional clinical trials hasn't changed in almost 100 years. And the way that they were set up was before we had computers, before we had calculators, we just had slide rules and we had books with tables of statistics. And so that really drove the way that clinical trials are designed. And because of that, we made rules that said you could not look at the data as it's coming in. You just have one look at the data and that's right at the end of the trial. And that's been drummed into clinical researchers for decades, that you don't look at data before it comes in. But now we have computers, we can actually develop algorithms that actually allow you to look at the data as it's accumulating. And that means that you can actually stop as soon as you've answered the question. So this idea of a Goldilocks design. With traditional trials, usually we don't enrol enough patients, and that's a problem, because then you either have to start again, or what happens most of the time is you say it's too hard. We will never know whether this treatment works or not. Occasionally we enrol too many. There's actually a big treatment effect, and we needlessly enrol people to a trial where we could have stopped a long time before. But with these new algorithms, these Bayesian algorithms, what we can do is look at the data as it's accumulating and enrol just as many patients as we need to answer the question, and then stop. And so that advances both in how we collect data, but also the computational ability to do these simulations, to do this analysis, should be transformative for how we do clinical research going forward.
So it sounds like these sort of big enabling changes have happened. The ability to get data in real time that's electronic, which has happened in lots of parts of the world and has been a bit slow in health, and also just this sort of computing algorithm type analysis capability that wasn't there previously that now is available. But why would clinicians and indeed patients be confident that your learning health system type approach is going to give them the sort of outcomes that they want, and confidence that, you know, medicine A is really better than medicine B, or treatment because we've got used to these
Yeah.
old ways of doing things, and if they're not like that, then we get a bit suspicious that we
Yeah.
mightn't be correct.
Yeah. No, it's hard because, as I was saying before, we've been ingrained with this traditional way of doing clinical trials, and in fact, most younger clinicians and junior clinical researchers and patients and participants themselves, you explain this to them and they think actually that makes sense. You would never get into a car and drive without looking where you were going, so why would you do a clinical trial without looking where you're going? The real problem is more experienced clinical trialists who are used to a certain way of doing things, and it's been a lot more effort to convince them that actually there is a better way of doing clinical trials, and that's happening slowly. One of the challenges is that the sorts of training that you need to be able to design and implement these trials is actually very different from the training and the experience that you need to do traditional clinical trials. We need people who are sophisticated at programming and sophisticated in computer simulations, and for a traditional statistician they don't have that training. So there is an issue that we need a new generation really to step up and to take the lead on implementing these new designs, because the older generation, they won't do it because they can't do it. So
yeah.
it's sort of the same issue. Why did it take London, decades to move from gas street lamps to electricity when it seems so obvious that we should? It's because it's a systems and a cultural issue, but it's happening.
And I think one of the problems with the traditional design of clinical trials was that rare patients with rare diseases, and patients now that we would regard as rare in the area of oncology with particular molecular makeups of their cancers, so-called precision oncology or precision medicine, they were poorly represented in the old system of clinical trials. So how would this approach benefit those patients who might be a very unique individual with a very unique disease?
Yeah, no, that's a very good question, and it applies especially in child health and in paediatrics, because we have a lot of rare and orphan diseases in paediatrics, genetic conditions where there might only be a handful of these kids in Australia, maybe even in the world. So you're right, a traditional clinical trial looks at the average effect of a treatment across a broad population. And so if you've got a treatment that is actually only beneficial for a small group of patients, it can be very difficult to see that, to find it. You're trying to find almost a needle in a haystack. You just won't see it using a traditional approach. With these Bayesian approaches, what we can do is we can predefine subgroups of patients. And in the cancer space, for example, they might be patients who have a breast cancer, for example, but we can define specific groups based on particular mutations or receptors that they may or may not have. And we can efficiently look at the benefit of a treatment in each of those subgroups without having to average across the whole population. And what that means is that we can more efficiently identify, actually, this doesn't work across all cancers, but in people who had this specific mutation, it does work, or this combination of mutations, it does work. And that's important because in the past, potentially very good treatments have been discarded as useless just because we haven't had the tools to be able to hone in on the treatment responsive subgroups.
So I don't want to ask you to sort of over speculate, but what do you think the upside of this could be to the health system if you just had to quantify it in terms of the outcomes for patients, the rate at which new things would get to the clinic, those sorts of outcomes separate from any savings in money or anything?
Yeah. So I think we've seen tremendous advances in health and medical research, as you know. This whole precision approach, being able to identify disease down to a genetic level or molecular level, develop drugs that target specific mutations. Really the bottleneck has not been in the discovery, it's been in the implementation. How do we evaluate these 21st century treatments when we're actually using tools that were invented 100 years ago? And so we need 21st century approaches to how we evaluate these things. So I expect what we will see with the broad scale implementation of these new approaches is that there will be a much faster and more reliable translation of these discoveries from the bench into actual practice, because we will be able to identify down to very specific groups of patients what treatments work, what treatments don't, and in whom. At the moment, the way that we evaluate treatments, for the most part, we can't do that. But now we have the tools to do it. So I think that will translate into better care and to better standard of living and quality of life and improve longevity in the long run.
Yeah, I think not many people realise that it really takes 15 years from the time something is first being tested in a clinical trial using the standard approach before you can go to a doctor and get a prescription for it. So anything that sort of reduces that time frame is a real positive for patients, both in terms of dismissing things that don't work and actually signing up for things that really do work. So that waste is really probably not evident to the average person.
Right, and so we end up having things that are discarded as useless, but we also have things that are effective but just take a long time to get implemented into practice. And so this will hopefully accelerate how quickly new drugs can be implemented into practice. Another bottleneck is created because when we approve a treatment as effective, the person who's paying for the treatment, which in Australia is usually the government, they want to be 100% certain that this is actually a good investment in funds. And what the reason is that we don't usually do a very good job in how we evaluate treatments after they've been licensed and funded. And so it's a big risk that the government takes every time they agree to fund a treatment. What we need to do is be a lot more effective and efficient in how we evaluate the treatments, even after they're licensed and even after they're funded. And that will give governments much greater confidence and certainty to invest in some of these innovative products, which at the moment they don't have.
So just for the last question before I think we're going to turn to some questions from the audience is I think everyone knows the impact of COVID-19 on the world and on Australia. What in fact do you think your approach has had impact on COVID, and what have you been able to do in COVID that you wouldn't have been able to do otherwise with your particular approach to assessing impact?
So I think COVID-19 has really brought to the fore the importance of learning as quickly as possible about what works and what doesn't. We haven't had the luxury of having decades of experience with a disease, and so there's been a great need and imperative to bring effective treatments into use as quickly as possible, because we can't wait 15 years. In 2035, no one's going to care about what the best treatment for COVID-19 is. And so what we've been doing is creating these platforms or designing these platforms that allow multiple treatments to be evaluated simultaneously. And one of the ways that we do that is through this thing called Bayesian response adaptive randomization. And what that means is that if you've got multiple treatments that you want to evaluate, you can actually, if you're looking at the data, you can progressively assign new patients to whichever treatments are looking most promising over time. So you don't have to wait for 5 years to implement the findings. People who are participating are actually benefiting from the treatment. I think we've got a video that shows that how that response adaptive randomization works.
Great, let's watch it.
Sometimes we want to study a number of treatments at once, so we may have many arms or treatment groups to analyse. If we fixed the proportion of participants in each arm so they were equal for all treatments, it would take a very long time to know which treatment is best. In an adaptive trial, we can adapt the randomisation ratios over time based on how well people respond to each treatment. For each treatment, we use the accumulated data to work out the probability that it's better than all others. With this information, we can update or adapt the randomisation proportions to favour the better performing treatments. This means that new people coming into the trial will be more likely to receive better performing treatments. It also means that we can more rapidly drop any treatments that are clearly not the best, focusing our efforts instead on the best performing treatments.
Okay, so I think everyone's now an expert in the Bayesian adaptive trial methodology. So can you now, before we throw to the audience for some questions, just give us some very concrete examples of how you're going to use this, and particularly in kids?
Sure. So we've got a few demonstration projects that we're implementing both in the kids' hospitals but also outside. And one of the more ambitious projects is to take this whole learning health systems approach to improve the management of cystic fibrosis. So you'll know that cystic fibrosis is an inherited condition that children who are born with cystic fibrosis, they have recurrent lung infections, and with every lung infection their lung function deteriorates until the point where they have trouble breathing with exercise, and then breathing just doing normal daily activities. And unfortunately still many Australians die from cystic fibrosis in early adulthood unless they receive a lung transplant. And so across Australia, cystic fibrosis treatment centres, both in paediatrics and in adults, they manage these lung infections in different ways. And the reason for that is that there have been lots of trials, but very small trials, done in a traditional way. And so none of them have ever been conclusive about what works and what doesn't. And so we've managed to get the CF patient groups through CF Australia, and also the cystic fibrosis treatment centres together to build what we call a learning community in cystic fibrosis. So they've agreed firstly on what the priorities are in terms of optimising the management of these lung infections. And we've got patients and their families who have said that they want their treatment data and their outcome data every time they have a lung infection to be systematically captured in a database. And then by the middle of next year, we're expecting we will start randomising patients to receive different antibiotic treatments for these lung infections, and doing it in this response adaptive way, so that people who are participating in the platform, their treatment is actually improving over time because we are learning from the experience of patients who have gone before them. And we just went live with that platform in the Sydney Children's Hospitals a few weeks ago, and already we've got almost half of all families of kids with cystic fibrosis who have signed up to be part of that platform, and we're expecting that almost all families will agree to participate, and it won't just be at Sydney Children's Hospitals, it will be CF centres across Australia, and we're expecting that this model we will be able to extend overseas as well. The more people who participate, the faster we learn, the more people benefit.
Yeah, that's fantastic and really empowering for families and kids to actually be helping others as well as themselves at the same time, which is just amazing in real time.
No, the feedback from the families, I mean, on the one hand it's yes, why aren't we already doing this, but it's been very positive.
Fantastic. I might hand over to Julianne, who has some questions from the audience.
Yeah, fantastic. We've got a question from Professor Russell Dale, Tom, who is the Clinical Director of Neuroscience Centre at Kids Research at the Children's Hospital at Westmead. He says, "Thank you, Tom, for fantastic work. Although electronic medical records are clearly part of the solution, his experience to date is that electronic medical records are not as flexible as they can or should be, and the quality of the data is only as good as the data inputted. Could you comment on how electronic medical records can be optimised?
That's a good question. No, I mean that's right. So we now, having had no data 10 years ago, now we are in a sea of data, and Professor Dale is quite right that actually a lot of that data is junk. It's data that was recorded so that by clinicians to almost like a journal of their activity. It wasn't recorded in a way that we need it to be recorded in order to understand what's actually happening, the treatment that's being given, and the outcomes so that we can learn from it. So we do need to be much better at, rather than capturing huge amounts of data, identifying what are the bits of information that we need, which are critical, and then focusing on capturing that data as cleanly and accurately as possible. And if we can do that, then we can learn very efficiently. So we think that about 20% of the data that is collected, we get 80% of the information that we need in order to improve care. And we just need to get a whole lot better at that. And if clinicians can see that the data that they're capturing is actually resulting in improvements in care, they will be motivated to improve the quality of the data that's being captured. The problem at the moment is the data that's being captured isn't always going into improving the management of patients. So there's no incentive for clinicians or other healthcare workers to put the effort in to make sure that that data is collected as accurately and as completely as possible.
Yeah. We have a couple of other questions.
Yeah, great.
So this one is from Nan Hu. How effective would the adaptive intervention approach be in dealing with mental health conditions, given that these conditions usually take a very long period of time to improve?
That's another excellent question.
Another tricky one.
Yeah. So that's right. In order for the adaptations, this adaptive process to work most efficiently, you need to be able to capture the outcomes relatively quickly. And so if you only can know the outcome of a treatment months or years later, then you can implement the adaptations, but they take a longer time to implement. And to some extent that's unavoidable. Some things like, knowing whether someone is cured of their cancer or knowing whether they're going to have a positive outcome from a mental health intervention just takes time. But there are things, even in those seemingly very difficult situations, that we can do. So one thing that we can do, for example, is by monitoring what happens to patients over time, after they've received their treatment, we can start to extrapolate forward to what we expect their outcome will be in 12 months, 4 years, 10 years time. And so rather than having to wait that 4 years to implement the adaptations, if we know even after 6 months that people receiving one treatment are doing better than another, we can start to use that information to implement the adaptation. So within these Bayesian frameworks, we have extraordinary flexibility to be able to use all of the data that's being collected without having to wait right until the very end for future patients to start to benefit already from the information that's being collected.
Great. 2 more questions.
Go ahead, Julia.
This one is from Chris Cowell, Director of Kids Research at the Sydney Children's Hospital at Westmead. Great presentation, Tom. Can the trial that you described for CF children and young adults adapt to include a new therapy after the trial has been implemented in 2021?
That's another good question. So yes is the simple answer. So that has been a problem with traditional trials, especially trials that take a long time, is that by the time you get to the end of the trial, there are actually new treatments that you've been waiting 10 years to bring in to test them, if you do it in a sequential way. But the way that we design these platforms, like the one in cystic fibrosis, is that we can actually implement new treatments into that platform as they become available. We don't have to wait until something gets knocked out or until the end of the trial. So these platforms are actually designed to be perpetual. So the analogy is like a sports arena. And so a traditional trial is like building a sports arena for every single game of football that you want to put on, and then once you finish that game of football, you dismantle the stadium, and then when another team comes along, you build the stadium again. Platform, you build the stadium once, and you set the rules and the conditions, make it the same for every competitor. That's every treatment that comes in. You evaluate them all in exactly the same way, and you compare them head to head, but you also allow new treatments to come on board as they're available. So that's another way in which this more flexible approach will allow us to evaluate and implement new treatments much faster than we've ever been able to before.
Great, and I think we have another question from the audience.
One more question. So is there anything similar being developed elsewhere in the world, and where does Australia sit in that, and your work in particular?
Yeah, so there are bits and pieces that are being implemented in other places. With the Institute of Medicine report on learning health systems, a lot of countries, a lot of health systems have come on board with the need to collect data more efficiently. So a lot of hospitals are now coming on board with electronic medical record systems. The real gap is in what we do with that data. And we are learning from these new clinical trial approaches that are implementing these Bayesian trials, which is coming on very slowly. So we have some learnings from the clinical trial space. We have some learnings from the learning health system and electronification of medical records space. But to our knowledge, no one is really putting those two things back together in exactly the way that we're doing here in Sydney. And then the third part is the implementation into practice. And that's what we really like about these adaptive algorithms, is that you're actually implementing the findings as you go. So we think that's actually quite a revolutionary step. And we think that, we want the kids in Sydney to be the first to benefit from this approach, but we don't want them to be the last. And we want this approach to be extended to other health systems across Australia and across the world, both in children and in adults.
Fantastic. Any more questions? One more question? Go ahead.
Again, from Chris Carl. Tom, do you envisage the learning health system approach being used in helping decision making in acute care situations such as emergency?
No, definitely. So it's hard to imagine any part of clinical care that couldn't benefit from a learning health systems approach. And a lot of our work has been in improving the management of chronic conditions, but it's also very applicable in how we manage children with sepsis, for example, coming to the emergency department, the sorts of treatments that we provide to children who come in sepsis, and how we diagnose sepsis and work out who receives what treatment, which are the kids who need to be admitted to hospital and who are the kids who would actually be safe to be sent home, who are the children who would benefit from antibiotics, and actually who are the children who won't benefit from antibiotics. So we're doing a similar approach to improve the management of acute gastroenteritis, improve management of lower respiratory tract infections in kids. We know that we overtreat lower respiratory tract infections. We know that most kids have got viral infections, and yet many of them receive antibiotics inappropriately. A lot of these kids are admitted to hospital to wait for blood cultures to come back. There's so much that we can do to learn better about how we manage these conditions. And one of our mantras in the learning health system approach is that we need to be learning from every patient. So we don't just learn from the 2% who participate in our clinical trials, we learn from 98%. So we want to go from learning from 2% of kids who come through the doors of the Children's Hospital to learning from 98%. And I think if we can achieve that, then we will know that we have a learning health system.
I think that's a great way to end, and a great point for everyone to remember is making sure that every patient is someone that we've actually learnt from and they've benefited and others have. So thanks for the conversation this afternoon. It's been really, really instructive. No matter how many times I hear it, I really love talking about it again because I think it has enormous potential, and I hope everyone's got a lot out of it this afternoon. And over to you, Julianne.
Great. I just want to especially thank Professor Tom Snelling for being with us this afternoon, and Professor Robin Ward. Robin, I completely agree. I too, every time I hear about this, it is really truly a pioneering initiative. We are incredibly excited to be involved, and would love to take you on the journey with us. So there's more information about Tom's project on the Sydney Children's Hospitals Foundation website. As I said, we'll send you a follow-up email after this. Thank you so much for your time and attention. The Foundation will be running a series of webinars next year, so stay tuned. Thank you for your time, and it's been wonderful having you with us.